Agron, thank you, Mitch. Hopefully Fatima and Dr. Konstantinos will be joining online, so they will be on that. Okay, thank you very much, everybody, for coming to this. I would say last but one, as I say, session, but a very important session, because we arranged it so that by the time we got to this session, we had got a very good idea of what the new landscape or ecosystem in healthcare was. The reason why we reserved this topic for now was post-pandemic, many things are happening, and the systems we trusted, we have great rift valleys in the middle of those. There have been rearrangement of other things, other new agilities, as Janice always says, that we started working amazingly, developing more trust. And despite what the geopolitics situation currently is, amongst patient groups, patient organizations, and patient networks, there is much closeness, much more trust, and much more creative, and also closer working shape with WHO, whom we have been thankful for having seen us through such a traumatic shock in human history. This session is now directly, I'm speaking to you, but I hope our voice can be amplified in the World Health Assembly on Monday. It's looking at the reorientation of universal health coverage. As you know, we were halfway through delivering universal health coverage until the pandemic hit us, and we are now very uncertain as to how we were going to achieve that deadline. But we've got a very good panel here today for you. We've got Dr. Tessa Richards, who's the Associate Editor for the British Medical Journal. So Tessa is the eyes and ears, not only of what's happening in the physician and the professional world, but also as a patient, and a deep-rooted involvement with the patient movement with YAPO and others, also knows what's happening within the patient movements. So this is one of the best patient healer doctor that you could ever look at a combination. Then we've got Judy Stenmark, who's the Director of Global Healthcare Federation. We have brought Judy in for a very particular reason, that during the pandemic, everything shut down. And guess what? We almost reached that 90% healthcare was self-care. I would say self-preservation to a larger degree. And so self-care actually got a great boost in that. We started taking responsibility for that. We did not leave everything to our health systems to address and so on. Then the most important speaker, who's I call the lynching, the linchpin of the whole train, you know, from stakeholders like civil society organizations, non-state actors, patients, and others, is Justin Koonin, who's the co-chair of the UHC 2030. Please join UHC 2030, and it's a huge movement, and the diversity of that movement is always amazing. That every time I see any news item, it's amazing groups. And the UHC 2030 is our collective voice for member states to make sure that we are on track. And then Raymond Anderson, who is the past president trustee of the Commonwealth Pharmacists Association. Raymond, we brought you here under the pretext for two reasons. Yesterday we had the Minister for Kiribati here, who took our message into the Commonwealth Ministers meeting that's happening today. It's ongoing. So the UK is leading on that, and we've got 56 Commonwealth ministers meeting up and discussing universal health coverage, by the way, how we can go back on track. So I hope you can help us put the pharmacists opinion, take it back. I think it's very important to bring the pharmacists in, because during the pandemic, we were relying on the pharmacists as the fourth emergency service. Yesterday we had Catherine Duggan from FIP with us, and there she said the agility is there developed, even to the point of delivering blood transfusion products to home and administering them was extremely valuable in patient experience and keeping us healthy. Then we have Agron Bytyqi, who is the chairman of the Patients' Rights Association in Kosovo. Reason why we are bringing that Kosovo experience is this: many countries now are in what we call post-transition state, post-conflict transition state, where the mess that's been left with by the conflict, the economic, the health system destruction and others, has left a huge gap which needs to be filled in by the patient advocates and bring some sense into that. So Kosovan experience is really important for us. The tendency for health policy makers to ignore patients in such situations needs to be counteracted by strong advocacy. If you advocate at 20 kilometers per hour, in normal state, you have to now go to 120 kilometers and still keep that safe driving speed in mind. Fatima Seedat is from South Africa. Fatima currently is in a country that's going through some amazing transitions, economic, social, and Fatima will agree with me. One of the biggest one is this power cuts that are happening, and patients who rely on health devices that power some of the pumps, battery chargers are in deep shock, and home self-care and everything is actually in a problematic. Even health facilities are struggling. And then Dr. Konstantinos is working with Better eHealth, and from the Norwegian Center for eHealth, they've just undertaken some research for the low and middle income countries in Africa and to look at how they can bring an eHealth to boost that gap that's been left by the standard care and the in-person health care. And I will now hand over to my competent moderator, Dr. Tessa Richards, to take over and lead the panel through this. And Tessa Richards always invites stories here from patients, especially patient perspective. If you've got something to say, do say to Tessa, and we will publish it in next report coming up. Thank you.
Kwali, thank you very much for your warm introduction. Welcome everybody here and those online to this session where we've got ambitious spectrum of things we're going to discuss and 6 speakers. Just a small thing, Kwali. The BMJ, I'd like to say that we're on a journey towards co-production of our content with patients. We're on this journey. It's very exciting, and for a major international medical journal to embark on this, and we do absolutely welcome hearing from you and the issues that concern you, but there is never any guarantee about publication in advance. One small point. Anyway, moving swiftly on, we're all aware of the huge, high-level policy commitments to universal health coverage and the extent to which, that's been blown off course by the pandemic, by climate change, of what we've been hearing a lot about that, where the impacts are accelerating, by current recent conflicts. And we're also aware, then this is the other major topic for discussion, that the vehicle through which to achieve this coverage is through strengthened primary care. And yet we're at a time where primary care has never seemed to be weaker. That's certainly the perspective I think many people in the UK would say, because of the shrinkage of the workforce for health. Interesting, in the town I live, which has been voted recently the most desirable town to live in, small town in England, our general practice has now closed There are no GPs running that practice. So if you can't get them there, goodness knows where you can get them. So self-empowerment, self-care couldn't be more relevant, couldn't be more important, and in fact has always been there. So I'd like to start off by inviting our expert speaker, Justin Koonin, to say, well, where are we? What's actually happened with universal health coverage over the last few years?
Thanks very much. Is the microphone, can you hear me? So terrific to join these wonderful advocates on the panel, and thank you, Kawaldeep and colleagues, for having us. So I will set the scene just to make sure we're all on the same page. So the first minute or so will be elementary to many of you. But so universal health coverage is Sustainable Development Goal 3.8, and it means that all people should have access to the full range of quality services they need, where and when they need them, without financial hardship. And critically, that definition has two components. First of all, it's about service coverage, so access to services, that's 3.8.1. And secondly, it's about financial protection. It's no use people having access to service if they can't afford it, or if they're pushed into financial hardship and catastrophic health spending to access those services. It's critical when we talk about the definition that UHC encapsulates the full spectrum of health promotion, prevention, treatment, rehabilitation, and palliation. Often these discussions are reduced to discussions about tertiary services in hospital, and that's obviously not why we're here. So sometimes we have to fight to make sure that in these discussions about UHC, that the full spectrum of services and health tools is included. And it's also critical, I alluded to Goal 3.8.2, that we think about how UHC should be financed. And the overwhelming evidence is that the driving engine for the achievement of UHC globally is through public finance. In other words, governments raising progressive taxation and funding healthcare systems that way. There is, of course, reason for development assistance to continue. Sometimes it can fund things that governments won't. It's critical, but ultimately 99% of global health spending comes from governments. Even before COVID, about half the world's population lacks access to essential health services. There was significant progress, to be sure, in the 2000s and the 2010s. WHO produces something called the UHC Global Monitoring Report every 2 years, which tracks a reasonably detailed UHC index, and it's not perfect, but it's a reasonably good description of what's going on. And that index globally shifted from 45 out of 100 to 67 in 2019. Nonetheless, half the world's population, as I said, did not even then have access to essential health services, and there were still 2 billion people facing catastrophic health expenditure to access those services. It's generally true that countries with more financial resources do better on the UHC index than those with less. In other words, there's a correlation between GDP per capita and the UHC index, but that correlation is definitely not one. There are countries with relatively fewer resources, and Thailand's a good example. Thailand introduced a reasonably effective system of universal health coverage in 2000 when their GDP was about $2,000 a year. And then there are countries with a lot of money, and I'm not going to name and shame, but I'm sure you can think of them, who do substantially worse than they could or should. So that was the pre-COVID situation, and then COVID happens. And in my preparation and preparatory questions, I was asked which countries were affected by COVID, and the answer is all countries were affected by COVID, almost all countries. 92% of countries reported some level of disruption to essential services during COVID. But what is clear that countries with stronger, more resilient and more equitable health systems fared a lot better than those that didn't have those. And our experience through COVID made it clear that, I mean, everyone's been talking about health security in the sense of protection against health emergencies. Our experience during COVID made it clear that you can't have that without strong health systems leading to UHC. And so when we strengthen health systems and make progress towards UHC, we're not just fulfilling the social contract governments have with the people who live in their countries around the right to health, which they have reaffirmed many times, but most strongly at the 2019 high-level meeting on universal health coverage. But we're also making progress on health security and health preparedness. And then to the particular focus on primary healthcare and by extension self-care, we have to remember that every country is resource constrained to some extent, even the very rich ones. And overwhelmingly, the evidence shows that the best bang for your buck, and I know you all know this, is through focusing on primary healthcare delivered at the community level. So we do need GPs in villages, even if they're very nice villages. So so this leads to the narrative that UHC 2030 has developed. I mean, we formed in 2016 out of the International Health Partnership, focusing on effective development cooperation, but increasingly since 2016 working on UHC, the narrative that to progress on both UHC and health security through the pathway is through health system strengthening with a particular focus on primary health care. Much more to say, and hopefully we'll have time during questions, around what's happening in New York, the high-level meeting, mandates from the General Assembly, multi-stakeholder consultations, but I think I'll stop there as an introduction. Thanks.
Justin, thank you so much for that very helpful overview and for your emphasis on just making it clear that universal health coverage is not all just about medicines and services, it's about prevention of disease and health promotion. I think we've got to be very humble within the health sector that people's health and well-being is determined far less by what happens in health services, which contribute about 10% towards all those other socioeconomic factors, education, the politics, which influence our health and well-being so much more, and I think we just always need to keep that in mind. Thank you also for your emphasis on the challenge of strengthening private primary health care, and also that making that very good point about the fact that you can spend a shed load of money but not do very well on universal health coverage. I don't think no country does that brilliantly, but some clearly do it better than others, and it's nice to have Thailand put forward as an example. Anyway, if we move on quickly now to Judy, who's going to who's, as you know, Director General of the Global Self-Care Federation, and he's going to tell us how we can all look after ourselves.
Thanks, Tessa. I have some slides. I'm wondering if someone is moving them. They are? Okay, there it is. Okay, thanks, Tessa, and thanks, Kawaldip, for asking me to join this panel. It's great to be here. I'm going to talk about self-care and UHC, and touch on the value of self-care and some of the evidence we have showing the value. Just mentioning pharmacists and health literacy, and our drive moving forward from the Global Self-Care Federation. So, next slide, please. I won't keep turning around. Okay, so how WHO defines self-care, and we work closely with WHO. We've been a non-state actor with them for over 40 years. But just reminding people in the audience, it's the ability of individuals, families, and communities to promote their own health, prevent disease, maintain health, and cope with illness and disability with or without a health professional. And it might involve using devices, and the definition actually goes on a bit longer. But WHO has made many supporting statements about self-care, and particularly in the updated guidelines of 2022. But supporting self-care interventions, according to WHO, helps strengthen national institutions and maximizes efficient use of resources, creates health sector innovations, which is interesting, and helps to improve access to medicines and interventions. So I think they're very important points. But next slide, please. Just showing you here the pyramid that was in the guidelines as well, with self-care right along the bottom there. And also you can see up the side, self-care is important all the way along, but particularly in the beginning when we talk about prevention, when we talk about health promotion, the community setting, and and you can see pharmacy-based services right across the middle there. And next slide, please. Just another way of showing self-care in the health continuum. And you've got healthy living, and you've got minor ailments where self-care particularly comes to the fore, but also NCDs. And I'll talk a little bit about NCDs. And, you know, we have examples, and we have examples during COVID. People don't need to rush to their GP to talk about or get advice about their osteoarthritic hips, for example, where they might have had the problem for a long time. And this is just an example where self-care slots right in there, and where someone can speak to their pharmacist and say, okay, look, what do I need now to manage this? You know, they're giving me a bit of problem. So self-care, critically important in the beginning or the prevention, health promotion part, and then continues. And of course, when someone is at the hospice, and it is, of course, less important. So next slide, please. Just checking I'm on the right, I'm speaking to the right slide. So self-care and UHC, we have a lot of reports and studies now on the cost savings of getting stuck into self-care, if you like, the savings to health systems, but as well as to the individual. And a big study from the US showed that every dollar spent just on using OTCs, for example, which is a part of self-care, can save health systems $7 for every dollar spent. And moving 5%, just 5% of prescription medications to OTCs, which is called switch, can save potentially about 16 billion to health systems. Also, individual empowerment. When we talk about individual empowerment, we're thinking here about health literacy, and critically important. And I know Carol always says there's no self-care without health literacy. And again, that's an example where knowing what you're doing, what you're taking, how you should promote your own health, and also the pharmacist here, again, in terms of health literacy and promoting that. And as Carol alluded to, self-care really shone a spotlight, COVID shone a spotlight on self-care, and just showed the importance of it, and how really that was all a lot of people had during the pandemic. And it showed that it worked, or it really made a big difference in many cases. Next slide, please. So this is just some pictures of some recent reports and studies that we did over the last 2 years during COVID. And the first one was the Self-Care Readiness Index that we did in collaboration with our partnership with WHO. And that looked at 4 enablers for self-care in 20 countries around the world. And again, IAPO and FIP were very involved in that research. But I just want to highlight how we really drilled down into health literacy there as a really, 2 minutes left, critical enabler of self-care. And then the other slide picture at the bottom is around our economic and social value of self-care. Next slide, please. Because we really need to demonstrate, to get legitimacy for self-care, because there's still a lot of people who don't agree that self-care is important, or really it doesn't mean much. So we need legitimacy. So we need to show really what is the value of self-care. And so this slide here is just showing, you can see cost containment to the whole health system, approximately $119 billion, and that's now. And then projections for the future in 10 years' time, 179 billion. But it's not just health systems, it's for the individuals, saving time, going to the doctor, where they can just speak to a pharmacist or get information as well themselves. Physician time saving is enormous. So, and productivity days, less time lost at work. Next slide, please. So, key asks in terms of self-care and UHC, integrating self-care as a key building block of UHC, and particularly in terms of investment in self-care and the management and treatment for NCDs. Next slide. I won't really touch on the pharmacist, but just to say that we see the pharmacist as really the pivotal healthcare professional in the whole self-care continuum. Second last slide, I think. Your resolution. Okay, so in terms of getting legitimacy for self-care, what we're looking at is where can we have significant change at a policy level. That's what really we want to see, because that's when change starts to happen at a national level. And so we've started this drive along with FIP and IAPO and many other coalition members to get a WHO resolution on self-care. It'll take time, but we believe there things can start to change. Next slide, please. And then I'll just go to the last slide. Next one. So just a promotion here. Next slide. On Wednesday, we're having an event in Geneva at the Geneva Press Club at lunchtime, and we have speakers from WHO. We also have COWDIP, we have FIP represented, and we have Imperial College London. And really, we're talking about self-care and UHC, and really how we can make that happen, and also our drive to a resolution, because it's only working together that we can do this. So if people are interested in joining this coalition drive and joining the drive for a resolution, speak to COWDIP about it, because he's very involved in that. Thank you.
Thank you very much indeed, Judy, for a great talk. I find it amazing that we need sort of legitimacy for self-care. We have a wonderful patient that we work with, a patient advocate, who puts up a slide which shows how she, with Parkinson's disease, spends, I just got to get the hours right here, 8,758 hours per annum in self-care and 2 hours when she's interacting with the health professionals. I mean, people with long-term conditions have no other option but to self-care. But what I think has been amazing about your talk is to put a figure on it. I mean, that amount of money is staggering. Yeah. And so if that doesn't convince policymakers, I don't know what will. Anyway, thank you so much.
Thanks, Tessa.
Next, I'm going to move on to Raymond Anderson, who's past president and trustee of the Commonwealth Pharmacists Association. We've already heard at this conference how the pharmacists have been manning the barricades when the GP surgeries were shut. Raymond, I'm sure you're going to explain more about this, and over to you.
I hope so. And thank you very much, Tess, and thanks for the invitation to come and speak at your Congress. I think Judy has laid a very nice foundation for what I will say. I personally am coming from a community pharmacist background. I have 42 years in practice at the coalface. So my presentation is about trying to put a context to, a sort of practical context to all that has been said. So if I could go to the next slide, please. It's just looking at how we move towards UHC and where pharmacy fits into it. It is something which I have always seen pharmacy being a key part of self-care. And I remember whenever I qualified, talking to a GP, and his view of pharmacy was that, patients who go to see a pharmacist first, and then if they go to see the GP, he already then is thinking of the next phase of screening. Because if they go first of all to the GP, he's starting at sort of at the base level. Anyway, so it's important to remember that it's about one profession. This is about multi-professional. It's about the need to move and involve all sectors and stakeholders in developing UHC. We've got to move away from the silo mentality. And as has been said, community pharmacy was during the pandemic, very much front and centre. And I remember even during those times, patients coming in and asking if I would be able to give injections because the GP surgeries were closed and they couldn't get their hydroxycobalamin, their B12 injections. And it was just, for me, it was a very say in-your-face change of the way we needed to work. So where we fit in, I just wanted to give you sort of an overall context of where we fit into self-care, and that is where we do provide lifestyle advice. We're looking at managing common minor ailments, supporting long-term conditions, and then the whole role of pharmacy prescribing coming in certain countries. And that's something I got qualified as a prescriber back in the UK in 2007, and was able to run clinics managing patients with long-term conditions such as blood pressure. But the increasing role then of vaccinations is also important. But there are challenges, and we'll come on to those. So next slide, please. And this has already been alluded to by Judy, and that is just where pharmacy fits into the whole self-care continuum. And I think it does cover it's more than just the, the services as such, but we do cover, lifestyle, managing minor ailments, self-managed ailments, and then moving into long-term conditions. And it's not that we are diagnosing long-term conditions, but it's very much about how we help patients manage those conditions. So I just want to take a few slides and look at each one of those 4 or 5 areas of work, and just give some evidence to show that, yes, pharmacy is delivering, but I want to also then at the end say that there are some major challenges which we need to address. So in terms of of COVID, community pharmacy has been able to deliver key services during the pandemic, though the problem is that we need key decision makers to endorse, articulate and support a clear public health role for community pharmacy, and that is about helping to deliver the policy of promoting self-care. Next slide, please. And this is really just showing where, in terms of lifestyle advice, pharmacists have been working in terms of helping patients about smoking, alcohol, diet, exercise, and increasingly in the role of vaccinations. And it's nice to see that evidently Cochrane noticed that and has actually published a piece basically saying that community pharmacies offering lifestyle advice, and what the evidence was that community pharmacies are well placed to provide opportunistic healthy lifestyle advice. But there is more work needed to be done in terms of the long-term benefits, but primarily those short, intermittent messages to patients and to just people who are just living healthy, living their lives, can be of real benefit. Moving then to the next slide, please. In terms of minor and common ailments, we do know, again, it's been alluded to and said very clearly by Judy, just people do buy, purchase, obtain medicines and look after their care before going and entering into the healthcare system. And pharmacists are able to give extra advice. It's not just always about just buying a medicine, because it's clearly sometimes just when you're buying something to just check it's the right thing for the right condition. Because there are times when, certainly over my years of experience, when people are just continuing to buy a particular product, and when you actually interact with them and engage with them, then it's actually something which they need either to be seen by their GP, or it's the wrong medication and they need to actually be changing it. So it's just about asking for advice and just seeing pharmacists as a resource rather than just a supplier of medicine. And again, the evidence for that is in the UK we had their 111 service, which was a telephone service, and people were being triaged by that service. And there was over 340,000 patients were referred to the community pharmacy for part of this, as part of the service. And out of that, 89% of the members said that they would trust their community pharmacist a great deal or a fair amount. And also that the overall evidence coming out of it was that yes, pharmacists were able to help support minor and common conditions. But as again has been said, there are real struggles in primary care, and pharmacists are in certain communities in the UK are losing their pharmacies, and pharmacies as well as GP surgeries are now closing as well. Next slide, please. And just touching on vaccinations, I just wanted to say, vaccinations had been through flu vaccination programs had been developing, over the years, and it was a matter of improving on that. And COVID really came in, and we've now got many pharmacies delivering COVID vaccinations. And I was in India in January, and the Indian pharmacists are now being trained up to deliver COVID vaccines as well. So in terms of long-term conditions, I just want to say that the World Health Organization's Global Action Plan talked about a recalibration and making a more people-centred approach to primary care and to the treatment of long-term conditions. And just the next slide, please, just to highlight 2 pieces of evidence, basically saying from the Cochrane Review, saying that pharmacists do play a vital role in improving patients' outcomes. And also then there was another piece of evidence from low and middle income countries, and that's in the Science Direct, community pharmacies on the front line in chronic conditions. They are not recognised, officially not really recognised as healthcare providers, and therefore in low and middle income countries we do need to see a movement towards that. So I just want to mention future direction, pharmacy prescribing. It is developing using the skills of pharmacists to manage long-term conditions, and the evidence coming out again is that pharmacists can prescribe equally effectively as GPs. And just finally, my last slide is really just the challenges, and the challenge are really, which was said earlier on by the representative from EMA, and also from WHO. It's about regulation, and it is really good to hear about the regulation, the regulatory body in Africa been set up for the regulation of medicines, but it's also equally important that we have the regulation of pharmacies and pharmacists. Some places the regulations are there, but they're not implemented and placed, and other places they're not there at all. And therefore, we do need to be seeking to ensure that the regulation of the profession is as equal as other professions. So they're not the possibility of the sale of, for example, antibiotics has to be reduced, and we have to begin to regulate the supply chain, and that can only be done if regulations. Good governance is always an awful word, but it's actually very, very important. I think that's the lot from me. Thanks.
Thank you so much. Raymond, I think it's very interesting. I mean, I just think maybe community pharmacists have turned into a new generation of barefoot doctors. They've become polymaths. They are...
The big difference is we don't diagnose, that we will not move into
Yes,
diagnostics.
no, I understand that. But it is an astonishing role that you've had to play during the pandemic and are now being asked increasingly to play in terms of prescribing and things. And I think your point about some regulation and sort of how this is all governed and works there is a lot that needs to be unpicking here. So thank you very much for thought-provoking presentation. Now, straight on, please, to Agron Bytyqi, Chairman of the Board of the Patients' Rights Association in Kosovo. I mean, goodness, we need to hear from you. Thank you.
Yeah, thank you, Tessa. Ladies and gentlemen, it's an honor to be here as a speaker at 10th Global Patients Congress. I would like to take a moment to thank the organizers, Kavaldeep and Dani, for providing this platform to share our thoughts and our ideas about patients' representatives. I'm Agron Bytyqi. I represent here Patients' Rights Association in Kosovo. Next slide, please. What will I present today? Kosovo has started reforming the health system, and I will mention the importance of civil society in representing patients. The need for organized structures of patients, which we called Patients' Council, and about present and anticipated challenges. Next slide, please. As Kavaldeep mentioned in the beginning of presenting me, we as a country have passed a conflict before 24 years. That wasn't not as itself the challenge for us, also the health system was a challenge. So we had a traditional approach until 2011. Called somehow physician-centric, with direct provision, where the patient was not seen as an actor in the health system. Kosovo still follows a traditional approach where the patient is not part of the system. The government manages, organizes, and directly finance the providers, and these have only served the patients. Somehow it's called Semashko type. Next slide, please. In 2011, the country decided to reform the system by orienting it towards healthcare with the patient at the center. So it's written in the health law that the care must be provided with the patient at the center. Although such a thing was proclaimed, it did not happen. Health staff were resistant to maintain the status quo of the most important actor in the system. The reforms creates mechanism to organize providers, but not consumers. From this reform, the buyer was separated from the provider, so it was created a fund. Also, there was created chambers, professional chambers. The union was, organization was progressed, but with patients was not working. This is also since at the time when the reform was made, there was no association for patients, and the patient's voice was not heard, or in other words, there was no one to raise it. Next slide, please. Seeing this lack, the civil society was organized as an NGO to raise this issue. This is how Patients' Rights Association of Kosovo was established, which has its own mission of empowering and protecting patients in the healthcare system. In the absence of the government's line of communication with patients, PRAK has initiated the establishment of an organized institutional structure called Patients' Council. Next slide, please. PRAK has advocated for the insertion of the Patient Council in primary healthcare administrative instruction in 2020. Representation of patients through the council is included in the statute of the main family medicine center. So this is the procedure which was done. Next slide, please. After the legal basis has been created in the statute of the main family medicine center, the piloting of the creation of councils has begun in 2 municipalities. The stages of creation was, as you see, with 2 points, a memorandum of cooperation between the municipality and PRAK, supported by the Swiss SDC office through the AQH project, soon to start with 2 other municipalities. Next slide, please. Why should be there Patient Council? Here we have the main aim to create an institutional space for communication between the state and the citizens, which helps us to increase quality of service, to fulfill patients' needs, to improve access on services, and to address the unaddressed concerns. There have been many issues that we have been collecting during the PRAK everyday work, so we have collected them, and we have seen that in this way will be the best represented and in continuous way representing in the institution and in politics. Activities, what does Patient Council do? Here is a list of activities that are included in the work regulations. So after they have been created, they have also signed a regulation, and there is a list of activities that they will do. Next slide, please. Next slide. Yeah. Just as every innovation which has its challenge, also this initiative had the challenge. Innovations open challenges in all society, but in our country, as a country in transition from socialism, does not have a great tradition of presenting complaints. Civic activism, it does not have much of tradition, which is a challenge to activate citizens. And the political spectrum is not very open to new ideas, so it's not very keen to accept innovation. Next slide, please. Recommendations. Organized society have the most powerful voice. So a mutual attitude towards establishing and empowering patient council or institutions alike among all nations is very important. If we join together in this cause of PRAK, or any of you who take on this initiative will be stronger. So if we are together in one voice, we are much stronger. Unique detailed guideline by IAPO or on how to build patient representative institutions will be very helpful for us. Way better have all these recommendations embraced by WHA. I don't know how many of you have this initiative or are being challenged in your countries, but what are convinced is that the sharing of experiences and the coordination of forces make us stronger. Thank you very much.
Thank you so much for that presentation, Agron. Very, very inspiring what you've achieved in terms of civic mobilization in Kosovo. And it makes me think about the effectiveness of the People's Health Movement globally in pushing for change, not least for universal health coverage. Depressing that it requires this, but just qualified by, he can't be the only one to have quotations, so I just want to slip a little one in here, which is around that, you know, all professions are a conspiracy against the laity, and I fear that this is maybe true of some of healthcare too, despite the well-meaningness of those who work in it, and the fact that, you know, you were mentioned here that the professions and, you know, the unionization of that. I mean, it's an interesting dynamic. So thank you for raising this, and I hope we'll hear more. Now, our next speaker is virtual, Fatima Seedat. Are you with us? She's the development manager of the South African Depression and Anxiety Group, and if pandemics taught us anything.
Hi. I'm not sure if you can hear me.
Excellent. Are you happy? Can you take over from here now? Thank you.
Good morning. I'm the South African Depression and Anxiety Group. I'm absolutely that I couldn't get physically to the Congress. I was looking forward to meeting everyone and being a part of the Congress in person, but unfortunately I couldn't make it. However, at the same time, I do feel extremely honored to be part of the Congress and presenting to you today, sharing our initiative and hopefully inspiring many people to join in or take part in the similar initiative. So just for background information of our organization, we are the South African Depression and Anxiety Group, in short known as SADAG. We are the largest mental health and patient advocacy group in Southern Africa. We were established over 29 years ago by our founder, Zane Wilson, who struggled with her own mental health. And due to her difficulties of accessing and getting diagnosed properly and getting treatment, she was inspired to start the support group. And 25 years later, we have a fully fledged office, 35 toll-free helplines that operate 24 hours a day, every single day of the year, SMS helplines, WhatsApp chat helplines, and through all these services, we reach over 2,500 to 3,000 people on a daily basis. We run awareness programs where we create awareness on various topics on mental health to ensure that people are being educated on different mental illnesses, to break the stigma around mental illness, and also to start creating conversations around mental health. We believe that education is part and key of prevention and intervention programs. We have over 183 support groups nationally. They could be face-to-face or online, and it covers various topics ranging from depression and anxiety to bipolar mood disorder, to borderline personality disorder, to postnatal depression, and many others. We run school talks to learners to create awareness around suicide prevention, to make sure that learners know where to reach out to get help when they are feeling overwhelmed, as well as we give talks to teachers in order for them to help them support learners if need be, but also to take care of their own mental health and well-being. Rural outreach programs play a very pivotal role in our organization. Due to the lack of mental health care in South Africa, where less than 4% of the annual health budget is allocated to mental health care, the rural community dwellers do not have easy access to mental health services. So through our outreach programs, we educate them about mental illness and mental well-being. We empower the people to open up support groups. We train lay counselors so they are able to assist wherever there's a need for them. And we do many talks so that people are aware of mental illness, but at the same time, they know when there's a need to go and receive help, and it's okay not to feel okay every single day. The main highlight of my talk today is to cover our 2 community counseling containers, which I will go in detail with. So I want to put into perspective a scenario. So I want you to imagine needing mental health care and not being able to access help, traveling a distance to receive mental health care and not being able to afford the transport fees, and you struggling just to cover costs, waiting in long queues at hospitals, knowing that you might be turned back and asked to return on another day, or knowing that you have a mental health condition. However, you are given paracetamol and saying your symptoms would subside, so go home and you'll feel better soon. Living in a hostile environment where crime, unemployment, rape, abuse, and fighting to survive is the norm. These are some of the mental health care users' problems that they experience on a daily basis. And this excludes all the other psychosocial issues that they may encounter over time. SADAG's Community Counseling Container Project was launched over 10 years ago as a pilot project in Diepsloot. The aim was to bridge the gap of mental health care by providing free face-to-face counseling and support to communities where there was little access in an already overburdened sector. The idea came from the need that was being seen through our calls that we receive on a daily basis. And in correspondence to that, the lack of mental health care in South Africa, where communities like Diepsloot do not have any mental health care practitioners visiting their clinics or being readily available to be seen in the area. About 75% of people living with a mental health issue cannot access help or treatment, which is a huge amount of people. Our blue container has now become a place where people see it as a safe space, where they can seek assistance for anything, whether it is to find out how to get an identity document for their child or to how to apply for a social grant, and leading towards very serious suicide attempts by individuals, to bipolar mood disorder patients, to people living with extreme levels of depression and anxiety. Our project not only services the area it's located in, but it is inclusive of the surrounding areas because it's so easily accessible. Over 300,000 community members can be serviced through these initiatives, and the initiative is so cost effective, which costs just under R1 million each year. Through our measurable success in Diepsloot, we were given the opportunity to open up a second counseling container in the middle of COVID, and it's now running for over 2 years. This is how our typical day at a container would look. Clients would be seated outside, queuing outside. It works on a first come, first served basis, and all the patients that come through are being seen to. Our counseling container has various services aside from just face-to-face counseling and debriefing, but we also engage closely with stakeholders in the area so that we can then work together in a network where we are able to provide a good service to those people that are reaching out to receive assistance from us. We establish support groups. So currently we have a men's support group, a mental health support group, for caregivers of mental ill patients. We do a lot of community awareness programs. So we visit local clinics, hospitals, police stations, malls, churches, taxi ranks, to ensure that we get the message across that there is help and hope out there. And we also, in the same time, educate people about the different mental illnesses that are out there, and that there are treatments for each one of them. We visit schools in the community, again, to cover our suicide shouldn't be a secret talk, but also other topics like bullying, substance abuse, and also creating a support net for the teachers in the area. We also started a new initiative where we streamline the process of our patients receiving medication and follow-up treatment. So we streamline the process where not only do we remind our patients of their follow-up treatments in order to keep them compliant onto treatment plans, but also we take them through the process of getting the medication and making sure that each and every individual that come with us on that day receive the help that is needed. The typical support group in our area. This is a
Okay. That was actually pre-recorded, so for time constraints, that has now been stopped. But I think we can all agree that it was very inspiring, I think, to see the creativity and the compassion of the community who's set up to provide this extraordinary breadth of services where there are no formal health services, psychiatric help and counselling for the many, many people with mental health disorders. So we'll move on swiftly to our final speaker, also virtual, Dr. Konstantinos, sorry, I don't mean they're virtual, but not here with us, Antypas, who's from the Norwegian Centre for E-Health Research. And take it away. Can you hear us, Dr. Konstantinos? Is your audio on? Anybody? Working on it. Thank you so much. E-health will indeed save us all. Telemed.
Manish, can you check it up? Can you make the connections? Manish? Okay, they're doing it, so keep them entertained.
Wonderful, thank you very much. Also, I suppose, sitting here listening to the discussions, I think this is relevant to all of them.
Dr. Konstantin, could you check your microphone? I think there's some problem. Yeah.
Around this whole business of peer-to-peer support, I think that's a very...
Carry on the discussion, and then I will try to get him back online again.
Okay, I think it seems to be an extraordinarily large support of self-care, and I don't think we talk enough about peer-to-peer support, what that can achieve, certainly in people with long-term conditions, where I have a sort of lovely anecdote of a GP who develops diabetes, and he said the only people who really helped me understand how to manage my condition were fellow patients. It wasn't the health professionals that I met. So I think that, within these patient organizations, there is a wealth of expertise that perhaps we don't even recognize sufficiently, and it's certainly not, it's not seen as part of a pillar of the health services. People don't tend to get referred for peer-to-peer support. There's always this.
Dr. Konstantinos, are you back on?
I'm trying. Can you hear me?
Thank you, we're back on, thank you.
Well done, well done. Welcome, a very warm welcome then, Dr. Konstantinos. You're going to talk about patient partnerships to enhance delivery through e-health and telehealth. So it's been so important, of course, during the pandemic. Thank you.
Thank you. And thank you for the invitation to present in such an important conference. I'm sorry I'm not there. I also see that would save us some technical problems. Luckily, there's no one's lives depending on the technical issues. So, yeah. I'm presenting here on behalf of the Better Health Project. It's an EU-funded project, coordination and support action, that is trying to see how we can improve e-health in low and lower middle income countries in Africa, not by developing some e-health solutions, but trying to improve e-health policy and also enhancing and promoting networking between actors and stakeholders. And stakeholders, patients, have been one of the important stakeholders in health, if not the most important, that unfortunately are not very often included in forming e-health policy, and to our experience, not involved in the forming of the e-health solutions either. If we can go to the next slide. So quickly, I want to address this question: if e-health can help with the health challenges of low and middle income countries, mostly in Africa, as our experience comes from the project, but I guess this can be relevant for the other low and middle income countries also. Just to point out that in this project we are 11 partners, and 5 of them are from African countries, and most of the knowledge we got in this project is from the partners we have in Tunisia, in Malawi, in Ethiopia, and Ghana. I'm the coordinator of the project based in Norway, but it's mostly their experiences, their knowledge I'm presenting. So there is some challenges. They've been also mentioned by previous presenters today. Some of them are related to delivery of health and universal health coverage in low LMICs in Africa. The clinical desert, as it's often called, the lack of or the very low coverage of health professionals per population in these countries. For example, in sub-Saharan Africa, we have 2 physicians per 10,000 people, whilst in high-income countries we have 13 physicians per 10,000 people. With nurses, it's something similar. We have in sub-Saharan African countries 13 physicians per 10,000 people, whilst in high-income countries we have 113 per 10,000 people. So there's a big difference there. But can e-health support in this? Can we support doctors and nurses and other health professionals to reach more people towards the goal of universal health coverage? And the answer to this question is that yes, the right type of e-health can really support doctors and nurses to reach more patients without even having to travel very often, of course, if they don't have the technical problems that I experienced today. But we see, for example, very good examples in radiology, where we do have radiologists diagnosing images over the internet, don't have to go to all the centers where we take X-rays or other type of medical images, and they can diagnose them centrally. Another example is the support of AI in diagnosing, and I've seen examples and my experience from these countries that are part of the project. I see a lot of activity in AI at the level of the rest of the Europe. For example, the experience I have from Norway, that can also, if they are implemented correctly, because there are also some problems, there are also some bias. A lot of AI data come from European or American data. But if we solve all these issues, AI can also enhance and enable doctors and other health professionals to reach more people. I see I don't have much time, but just to mention that we have other problems, like the care health system and facilities are inadequate, very few. We have long distances and poor infrastructure, and then we can see that e-health technology can also help to improve both the facilities, access to facilities from distance. Maybe you can invest in fewer facilities or the existing facilities, but increase the access through the help of technology, if it is the right type of technology. And also telemedicine is a very good tool for delivering health advice and health services over distance. Again, it needs to be functioning properly. We do have low literacy and low digital literacy, both at health professionals and citizens. This might be a problem with e-health, but also the right type of e-health delivered in the right way, and building the skills of both the health professionals and the patient can also be very important here. The other challenge that we do see both with universal health coverage but also in e-health is the limited funding and the dependence on donors. There is here also things that we can do to improve them, but there is also a huge potential from e-health to provide health services at lower costs. Our experience is that even though we use it very often as an argument, there is not so much focus on lower costs, and e-health actually ends up costing, I'm not saying more, because usually it covers services or deliver services that were not delivered before, but it usually costs, and this is one of the barriers for implementing e-health. But in the long term, it can reduce the cost and can make health services more effective. Fewer people can deliver, or the existing number of people can deliver services to more people over long distances, and we believe that they can be of better quality. If you have, for example, journal data, you can improve the quality of the service you deliver, and you can also monitor the safety of the patients and of the service you deliver, follow up the delivery of medications, side effects, and generally make sure that the quality of the services that are delivered are of the right quality, of good quality, and continuously improving quality. Just the next slide very quickly. The thing is that we do have, if you can show the next slide, please. We do have I'm not sure, I don't see the next slide, but maybe I can finish here saying that no, just okay, not that, please. I can just finish here saying that e-health is promising for supporting healthcare systems to reach universal health coverage. But as you can see on this picture, the patient that is not there should be in the center of the stakeholders, improving both e-health policy, but also the formulation of e-health solutions. Thank you.
Looks like a very promising project, and I'm sure that there's a lot around the role of e-health and telemedicine, and maybe chat all the problems, and maybe it can't, but it seems to me one of the key things here is that the development of these new technologies and their rollout's got to happen if you want buy-in and effective use of them. Right, well, we're going to move on now to discussion with the panel and various questions. And this is an exciting session, isn't it? People come and they go, and I'm delighted to welcome Marjorie Nicot. I may not pronounce your, forgive me if I've got your name pronounced wrong, who is very kindly standing in for Justin Koonin, who had to leave us. And as you're here, welcome. And perhaps we've got a couple of quick questions for you, which is, I mean, you know, is there enough in this drive for universal health coverage? And we've got a 2030 deadline, which sounds very optimistic. Do you think patients and civil society in general are being involved enough in this? How can that be strengthened? How can they help move this along?
Yeah, my short answer is not at all, unfortunately, but this must change, and we have an opportunity to make this change, and this is actually a point that Justin Koonin had included in his preparation, and this is something that UHC 2030 stands for, strongly behind social participation, meaningful engagement of people and communities, and obviously, you know, when we talk about universal health coverage, we have the service coverage dimension, we have the financial protection dimension, but then we miss out a major pillar, which is governance. And with governance, we know that reforms well, governance make reform happen or not. And here we've heard about people self-care. We've spoken about many things where it's about people, right? And people need to be empowered, and this needs to be institutionalized. So at UHC 2030, in the lead up to the UN high-level meeting, we make a strong call to institutionalize the involvement of people and communities in decision-making and review of progress about health that concern them and of course us. We know that this is critical, and government are not used to do it in many countries, including in democratic countries, or they don't have the time. And we know that during COVID, building the trust was critical. So it's time now to move. And we know that when we engage civil society and people in a transparent manner, I mean, we have better outcomes and we build trust. And patient groups and organizations represented here, you play a critical role. So we call on you to join, enforce the UHC movement and join us in promoting the action agenda, which includes among 8 areas, one about institutionalization of people's and communities' engagement.
Thank you very much. That's very heartening to have that response. So thank you.
We have a path to follow up, because a UN high-level meeting alone will not do it, and there are exciting plans also to have a resolution next year on social participation at the World Health Assembly. So maybe we can work hand in hand to learn from each other how to make this happen.
Yes, I think there's much to be learned about it. Just another question, if I may. Primary health care needs to be strengthened, but, you know, medical professionals are trained in ever smaller specialist silos. There's still a culture within the medical profession that, you know, that's the way to go, and that primary healthcare, well, perhaps you can leave that all to the pharmacists now. But so, you know, what needs to be done to strengthen primary healthcare, which is the bedrock of this universal coverage?
Yeah, good question. Very often primary healthcare is perceived as like, you know, poor healthcare services for poor people, right? But it's basically the bedrock or the foundation of universal health coverage. So basically it's about, you know, asking our governments to prioritize investment in primary healthcare, which provides the platform for an integrated, you know, approach to deliver you know, all services focused on people, and with, you know, people being at the center, and it has this strong dimension of you know, people being you know, the kind of center. And talking about low and middle income countries, we've seen some of the problems arising from focusing on disease rather than people.
Thank you very much for that. Judy, Stenmark, if I may turn to you next. You've given us an excellent talk around the importance of self-care and staggering figures about how much difference it makes financially. But I want to ask a question about, so where do you start this? I mean, we understand the fundamental importance of health literacy. Do you think enough is done at schools level to make children aware that, you know, that their health is to some extent in their hands, that they have a responsibility for that? It seems to me that, you know, teaching literacy when you've developed chronic arthritis at 55, you know, is a bit late. So what do you think we need to do to make this self, you know, care movement, you know, put more energy into it and grow it?
Health literacy, that's a very interesting, excuse me, question, and it's an age-old question, and we've been talking, well, I think people in health care fields have been talking about health literacy for well on 60 or more years, and no one's come up with the magic bullet, whether it's high-income countries or it's low and middle-income countries. It's something that's talked about all the time. In fact, we had a recent meeting at WHO in health promotion talking about, you know, who's done the best, what country has done the best in terms of health promotion, or what project. And really, there's no one thing. And but it is critical in terms of management, in terms of health promotion, in terms of disease management, or illness management, if you get it. And in terms of curricula, that's a really interesting question, and it's something we keep bringing up. I think it's more and more schools around the world, in some places, do have more conversations about health and wellness, etc. But I think probably what's easier to change may be the curricula of healthcare professionals in terms of health literacy, how you speak to people, how you convey educational messages in the right way. And I know pharmacists are doing a lot of work around this, and probably Raymond could jump in, because they're in a unique position to enhance the health literacy of people coming in to their organisation. And Kawaldip as well always likes to jump in about QR codes. And instead of people getting, you know, their long leaflet, you know, in a small box of, let's say, paracetamol or something like that, could be an OTC, that there's just a QR code that people could use that could say, okay, these are the side effects, you know, this is how you should take it. But it's a very difficult question. I think changing the health curricula or including some more about that in the healthcare professionals would really help, but that's also extremely difficult to move quickly on that. But I think we need to be doing more, and we're talking more about self-care literacy as opposed to health literacy, which is something that may come up in the future.
Thank you very much. This is a question that perhaps spans both you, but I'm going to sort of Raymond for it. Is one thing that worries me very much as a patient which is the fragmentation of the health record. So you're going to lots of different providers, and now this includes the pharmacist. He's giving you advice, and the patient is the one person who is present in all these different consultation situations, and they're given a lot of information, and they're advised to raise their understanding, literacy, read all about it. But what they're not given in many countries, and including still in my own, is they're not given full, free, immediate access to their own health information. Now, it seems to me fairly obvious that you can't manage your finances if you can't access your bank statements. So how on earth are you supposed to manage your health and, be literate and use services appropriately if you can't access your own health records? Should this not be right up the agenda of countries? This seems like a basic human right. It is a basic human right, we know it is, but it can be very difficult to get hold of your health information. For some, for technical reasons, for interoperability reasons, but some, again, is this a sort of hangover of paternalism, that somehow, those notes belong to the health professionals and, we'll tell you what you need to know. So Raymond, sorry, that's a bit offbeat for you, but I do feel that as community pharmacists are taking on bigger roles, this must be frustrating for you too.
Absolutely.
Because you haven't got access to the GP's notes, have you?
No.
But a patient could have them on their handheld, and if they did, it would make their interactions with you and everyone else a lot safer.
I think it comes back to, I'm not sure who alluded to it, but it was, where decisions are being made. I think governments have a key role to play in setting policy and strategy and direction of how we begin to develop the UHC, how we then, and it's from those policies and strategies that we, professions, patients will then begin to, as stakeholders, roll those out and begin to enact them. Now, I know in the UK there's different care records. England has got one, Northern Ireland has got another one, which is where I'm from. And the role that we have always argued as pharmacists, we need to, if we want to fulfill our role as providers of healthcare, and that can be right through to public health advice, some understanding the record of a patient. Let's say an example is whenever a patient comes in for it was a young girl, or probably in the 20s. This is going back a number of years because it was whenever they were changing the use of a particular drug. And I asked her when she sort of got diabetes, and she turned around and said, "I don't have diabetes." And it was for polycystic ovaries they were using metformin for. So it was a new use of a drug, which I hadn't been informed of at the time because it was new, it was coming through sort of consultant-led issue. So it can lead to embarrassment, it can lead to a lack of understanding from my part, but also then doesn't provide confidence to the patient. Whereas if you've got access to the records, that does help. And I know there are projects going on, and in the UK there is access now beginning to come through for pharmacists to have access. It's normally a read access only, but I think we need to move to the writing access so we can actually write on to the records. And I know there's been a project looking at UTIs in Northern Ireland where pharmacists have been involved in prescribing antibiotics. But to get that pilot up and running, we had to have a very limited access to the patient's drugs and their allergies. That was basically all we got access to, the drugs and allergies. And also the reason for that was to see if they had been on antibiotics previously and in the last few weeks or months. So let's say it's beginning to move, but it does take government policy and government strategy to really begin to, and then we can begin to build systems in place to actually provide that better care.
Thank you very much. And it's having a voice in the policy making, isn't it? I'd love to go to you, Agron, for us to really change what you've been able to achieve, these patient tools, and in cost it made a difference.
As I mentioned in my presentation, the representation of patients in institutions and in policymakers was not until the association was established. So we have think that creating this structured, organized patients, as we called patient councils, it will be in continuously collecting all unaddressed issues that they have in the primary health care. So also it's written in the administrative instruction that there will be in a steering council in the primary health care as a representative from patient council. So they can have their voice right in the institution. So, but it's very difficult, like in our countries, which we are in transition, to make these changes. It's very big challenge. So what we have done, we have also found politicians and convinced them to join our cause. And they somehow have accepted and raised the voice into the parliament. Also, we have done a memorandum of understanding with the Ministry of Health to be represented in all working groups where are done documents and policies about putting the patient into the center, not just written in the health law or in documents.
Thank you very much for that. Unfortunately, we can't go to Fatima. Obviously, she's not there, and we've got very little time. So can we perhaps...
We can extend it. Yeah.
Oh, okay. Konstantinos, then, very quick question, I've already alluded to it, is that do you think in projects and in telehealth and e-health projects in general, there's enough patient involvement in the actual design of these, you know, how these new technologies are developed and rolled out? So often, it seems to me that someone makes a decision in an ivory tower and they don't think about co-design.
Yes, definitely you're right. The current situation is that patients are not involved, citizens are not involved in the decisions about the way direction, what kind of e-health services should be prioritized, and the way what kind of elements they will offer. And what you commented was very correct. This with access to our own medical data. And it seems that if patients were involved from the beginning, when we were designing these issues, we would have access. This is the main thing we want to know. Also, like, we want the doctors to have and the nurses have access to the important data for us, but also that we can have access to them and share them with the health professionals we want, and also consult with them to make our own decisions and support our self-care. So, and I think this is and several other issues that would also be avoided if patients were asked, if the patients were in the center of the developments in e-health. And here is an opportunity. I will bring it back to low and middle income countries. Is that since sometimes some of the systems are now developing there, we have the opportunity to include them from the beginning. And if we include them, we will make sure that the right access, the right expectations, the right requirements will be in place. And for that, we need patients in the formulation of e-health policy and of formulation of e-health services.
Thank you very much indeed. Fatima, I'm so sorry. I'm absolutely delighted that you are here, as I absolutely want to congratulate you on this incredible initiative that you set up. It would be lovely if you give us a bit more feel for where you cite these sort of so-called containers, these safe spaces where people can talk. And if they're sort of painted bright blue, does the fact that you walk into one, that might carry a bit of stigma in itself, or I don't know, maybe, but it's fascinating. So do tell us a little bit more about how these work.
So with the blue containers, it fits within the community, and even though it's bright blue, over time the stigma breaks around mental health because of the awareness programs we do and the conversations we have within communities. So we go out into churches, clinics, schools, into malls, talking about mental health. Through that, we sort of break the stigma. So when we started 10 years ago in District, what happened was there were very few people that would be willing to come through and get the help they need. But over time, we've seen a marked where now the blue container is seen as the space where people can turn to regardless of what they want to know. They know they'll receive support or get an answer for something they may need. And it doesn't have to always be related to mental illness, but it's on a broader scale where they could ask us about anything from birth certificates to how to get help to get a social grant. So over time, this blue container is very bright in blue, and it can be seen from many places. But it is a place of hope and safety for many of the community members because it's the only place they see they can share their ideas, their thoughts without being judged.
Thank you. That's so helpful to remind us that this is so much more than just sort of mental health problems, and it's a safe space where any vast range of things can be discussed. It's very interesting. I don't know if any of you know Victor Montori and his book, The Patient Revolution. If you don't know it, please read it. Slim volume. But he was talking recently in London, and he's by the way, a diabetologist from the Mayo Clinic, and he says that actually the biggest innovation in healthcare is the unhurried conversation with a patient. It's not AI, but that's where the value lies anyway. So it sounds like I'm straight off to find one of these containers. It's brilliant innovation, and maybe we can do some more on the BMJ about this. Anyway, have we got time for any
yes.
questions?
Yes.
Not quite sure when lunch is.
Yes, I'll be getting. Firstly, I'm just thanking all the NSAs in official relationship with WHO for coming to our venue, and I think you've got lots of questions. This is those unhurried years we are talking about. Listen to that, Henrik. But online, there's one question. This is for Fatima. Does the color of the containers matter? I think this guy must be a Van Gogh followers, that when he was in his depressed bipolar state, he would paint blue, and when he was happy, he would play orange. Do you think the color of the container does matter?
I don't think it does matter that much, especially because what we wanted to do and the whole idea behind the bright blue was to be identifiable in the community. So for us, it was basically just so when we get there, people know who we are, they can find us easily. And from afar, you could see our containers from the street level. But if you look at it from a mental health perspective, blue is a very calming color as well. So while our clients are sitting there and waiting to be seen, because it works on a first come, first served basis, and sometimes the queues are quite long, just looking at the container creates a calming effect for them, and that's what we hope for. That's why the blue container is there.
Thank you very much. This is a question for eHealth Norway. I think that what they meant could be it's Dr. Konstantin. Do you think Africa should invest more in super broadband highways or super roadways?
I think it's a difficult question for me to answer. I know that investing in good internet infrastructure would also be very helpful to promote health if you have the right type of e-health services. Of course, still we need access to advanced facilities. So you cannot, it's in the very far future that we can replace completely the access to facilities. So a good balance would be important.
Thank you very much. And I now ask the audience, Bana? Oh, good.
Hi, thank you, everyone. Great comments and context. I'm just curious, in the quest for universal health coverage 2030, I know that, the dynamics are, oh, sure. Hi, I'm Carrie McDonough from New York City at Syneos Health, advocate for decades. I'm just curious, I know you talked about financial protection and service provision. If there's any sort of universal or alignment around what does adequate service protection and provision look like, and how do we make sure that it's not politicized? I mean, we're definitely seeing that in the United States in terms of women's health and other aspects. And so how do you sort of think about that in also a cultural context?
That's a great question. I think certainly from the US perspective, it seems to me that there's a lot of concern about what is defined as essential, and people have very different views of this. And the worry is that we know we live in a world, not least in the US, where there is too much medicine, there's overdiagnosis, overtreatment, and at the same time you have pockets where there is absolutely no treatment whatsoever. And I think that's got to be grasped, because I think we really do need to know what these, what essential covers. So thank you for raising that. I don't know whether you've got any comments to make about that.
Well, WHO has developed a compendium of the full range of services that should be part of this so-called essential package of services. And of course, then there is no kind of one-size-fits-all approach. So in every country, I mean, it's important that there is a dialogue between the government and all stakeholders to define, what needs to be included, and considering also that there is also a kind of progressive realization of universal health coverage, and it depends on the on the needs in the population, the disease burden, the epidemiologic situation. So it's a kind of menu, but it's quite comprehensive, and of course we all need to advocate for it to be inclusive of all the different dimensions, including physical and mental health, and preventive, palliative, promotion. So. Yeah, it's complex, but
it's complex and challenging going forward, given all the new sort of.
But it's important to see this as a kind of menu, and you never even you never achieve universal health coverage. It's a constant request, because even in the UK you see that there are problems on the way, or when you have aging population, you need to adapt also your what you provide to your population, what you cover.
So I got some more questions from the floor here.
Thank you very much. I'm Flavia Chomkama from Uganda, and I represent a patients organization, but also I'm a patient. I live with HIV, and I've recently undergone cervical cancer surgery. So my question, and what is perplexing me, is the fact that we are putting high on the radar for information the pharmacists. And when I look at my country, where we have a lot of over-the-counter medication, no prescription, you can go anywhere and you buy medication. I'm wondering how we are going to ensure that we are safe as patients, and also that the pharmacies, do they also go to the dentists? I mean, to the what do they call them? These ones who give the medication over the window. Are they the same? So it's quite difficult, because right now some of our medication antimicrobials are being given to pigs, to chicken. So the resistance that is going to come, especially when we highlight more the role of the pharmacists to provide the medication, the information. And then the second a bit about, is for the gentleman from Kosovo, is about the patient's relationship with the other stakeholders. We do have a national community health strategy, and for us, we are side by side. We are not below. We are like, it's like on one side, you have the ministry, you have national coordination, patients organizations. You go to the lower level, you have another level. You have the lowest, the health facility, you have community peers and support groups linking directly. So I don't know whether it's how it is working or you are just coming in from the bottom top, because I would think it's like a mutual kind of engagement relationship that we should have with service providers and also the government. Thank you.
Before the panel goes ahead, could I ask our chair, Neda Maska, she's heading the AMR Alliance, to say how we are tackling this quickly.
So I really am sorry for taking over. It's a great panel, although I had to go in and out for a short while. So on antimicrobial resistance, as you know, and as with patient safety, is quite cross-cutting, and it's very difficult to get on board patient organizations working exactly on antimicrobial resistance. And it is very theoretical concept. So how we tackle this is we try to, first of all, make the messages closer to heart or closer to the everyday experience. And secondly, try to gather all the different resources so that each different disease or disease areas or types of patients can relate. Meaning antimicrobial resistance is not only relevant for infectious diseases, it's relevant for MCDs, for surgeries, for cancer patients. Now we just talked with Diego for rare diseases as well. So what we tried is we organize an antimicrobial resistance patient alliance based here in Geneva, hosted by the observatory. But then it's too broad a concept, and I agree with what Tessa said earlier. So we have to tackle everything between excess and access. So wherever it's overly available to wherever it's not available. In the sense of antimicrobial resistance, this really pinpoints to increasing resistance, taking something that is not relevant for a specific infection or not taking anything for something that needs medicine, or overly taking if it's not needed. And in that sense, we try to then organize regional hubs, because the AMR is really region specific. In Europe, we might have access, or in US, but then in Africa, we have an issue with access. So a call, everyone that is interested to hear about this alliance, please visit the website of the observatory. There are links to the call to action, and so we try to spread. Sorry, Tessa.
No, thank you very much for alerting everyone to this. I presume you're taking a sort of One Health approach, and you've got the sort of agricultural veterinarians on board too, because
Yes.
as Flavia's already suggested, this has got to be an intersectoral approach to dealing with this. But are we allowed to
Yes,
please give Raymond a quick minute on
yes, please go ahead.
the pressures? I mean, one of the hardest things being a GP, and I have been a GP at some stage in my life, is resisting the patient who wants an antibiotic and you don't think they should have one. And GPs are actually trained to deal with uncertainty, and I think that's one of their strengths of good primary healthcare. And you can say, well, I don't think that there are all mechanisms like either not prescribing or saying, well, here's a prescription, but don't take it if you find you don't need it. Just wait 2 days. I think this is going to resolve. But is that harder for pharmacists? What role can they play in? I mean, it's not just overuse of antibiotics. It's overuse of medicines in general. We're putting a lot on your back, Raymond.
But I think one of the things, and going back to the Uganda, I was in Uganda a number of years ago, and it comes back to something you alluded to at the very start, and that's workforce. If we're going to deliver universal health coverage, we need a workforce which is fit for purpose. And my understanding in Uganda was, when I was there was 350 pharmacists on the register for a population which was almost the size of the United Kingdom. So, that's just not going to deliver universal health coverage when it comes down to supporting, self-care. So that's just the one aspect. In terms of the antibiotics, yes, the delayed prescription was sort of classically used in the UK, but patients, when they brought them in, were expecting them to be dispensed. So they were, and all they had to do was say, yes, I need it. So it's about education it's about an education of professions. And I know the pressures on GPs wasn't even sometimes about if they didn't want to give a delayed prescription, it was the fact that if they didn't think a patient needed it that day, 2 or 3 days later, the patient, if they felt they weren't going to get an appointment quickly or easily, then they would put more pressure on the GP, because they say, look, I can't get an appointment, so just give me the prescription now. But I think there's also a wider issue, and a colleague of mine, when they were in India, visited 3 pharmacies, this was in January, and asked for something for a cough, and got ciprofloxacin 500 milligram, a potent antibiotic, in each of those cases. Which brings me back to the position which I said earlier on. We need regulations in place, and we need people who are prepared to enforce those regulations and establish that. But at policy level, I think pharmacists should be involved at policy level, and that's where I think in a lot of low and middle income countries they're not, because it's very much medically orientated, and frank, that's just something, when it comes down to policy, we need to be involved in pharmacists at that point. And we're also involved in a lot of antimicrobial programs in Africa at the Commonwealth Pharmacists Association level, and that has been supported by the UK government through their Fleming Fund, which is one of their funds for supporting overseas development aid.
Sorry,
Yes, thank you.
I think this is the last question, then we'd better wrap up. I'm terribly conscious that you didn't get a chance to respond to Flavia. Have you got... Yeah.
As I heard, Uganda has very well representation of the patients in each level of institutions. That's why I mentioned that in transitions countries, it's very important to raise the issue of patient at the center, and working in practical how to see that it's implemented. And for that, we have created these patient councils, and we are working on it, and that's the reason that we have asked from the AAP or WHA to have a document that we can use it at politicians, because the most often questions of politicians were, why do we need patient councils? Which country has it best implemented? Or do you have any recommendation or any directives or any resolutions that it can be relied on? So that was the reason that we have asked for a document where we can use as for instructions.
Thank you. My name is Bessie Bright. I'm a member of the board of IAPO, and I run an organization called Live Well Initiative, LWI, in Nigeria. It's a wellness NGO, and we're into hepatitis and other disease conditions. I listened carefully to Judy and Raymond, and I found that Judy painted a very good picture about the role of the pharmacist. I'm actually a clinical pharmacist and a public health practitioner. So Judy painted a very good role for the pharmacist, but Raymond, the past president of the CPA, Commonwealth Pharmacists Association, painted a fairly gloomy picture, and I got confused, because really I come from the developing bloc, and we are trying to bring out new roles for pharmacists, and I talked about the role of pharmacists yesterday in the medicines world in Africa. So I was wondering why, as a past president of the CPA, the Commonwealth being so influential, I would have thought that the Commonwealth Pharmacists Association would have been able to influence some of those policies. But now that we have a new head for the Commonwealth, I think that's an opportunity to start all over again. But with Judy, I think that Judy has given us a lot of hope, and I hope that that hope will continue to build on it. I was actually supposed to speak at your conference last year. I hope I'll be able to do it this year. So I just wanted to find out why that gap was there. And the question from Uganda kind of highlighted what I was talking about. But we don't have such gaps. We do have gaps in Nigeria, yes we do, but we don't have such gaps where a long-standing patient would not know the difference between a physician, a pharmacist, and a dentist, and so on. But it's just something for the pharmacy world to look at it all over again and work a bit more. And I want to thank APO for the opportunity of highlighting the role of the pharmacist. Thank you.
Before the panel answers, we have just one more question. Take it jointly. So that will be the last word, okay? This is the younger voice. This is the future of our healthcare.
Hello, I'm Dr. Neil from India, representing the International Federation of Medical Students Association. So I have a question. With rapid advancement of digital innovation, how can vulnerable population or groups, especially women and adolescents groups, be protected by privacy and patients' confidentiality breach concern? What major steps would the private sectors and government take to involve the youth and youth-led organizations having the future healthcare providers to curb the situation? Thank you.
Thank you very much for that question. It seems to me that of all the people around the tables, tomorrow's doctors are crucial players. And I think around this, you're presumably driving at, data confidentiality. And I think this, and who that, patients are very concerned who their data is being shared with and for what purpose. And I think this is one of the things that if patients have ownership of their records and they can then decide who they share it with, I think that may well be the right way to go. I think it's a very important issue. Does anyone else want 2 minutes on, half a minute on this, and then we really must wrap up?
Not on that, I want to come back on the pharmacists.
Oh, hang on, what, more pharmacist talk?
Well, on the question from Nigeria.
Okay, 10 seconds from our pharmacist.
Just from your perspective, Tessa and Judy has given a very positive viewpoint of pharmacists. I wasn't trying to bring a negative one. There's challenges, and the challenges are in the workforce, and the challenges are in training. And it is my last slide. And the last slide that I put up, there are just issues which we need to address. And I think it's important that we don't that everything is rosy. So it's about being realistic and seizing the opportunities.
Was a long 10 seconds. Anyway, so I think I've probably only got 5 seconds. So please don't set your watches. But it seems to me we've covered an awful lot, perhaps too much in this session. But for me, perhaps 3 main messages: that universal health coverage, it is the money, but it's not only the money, it's the political will. And there's a big issue around the workforce for health being adequate to deliver universal health coverage in all its facets, not just deliver and dispense medicines and medical interventions. And I think there's no doubt that the workforce for health has got to include, apart from all the professions allied to medicine, we haven't heard much from them, but also, except for the pharmacists, patients and their families. They are crucial members of and communities of the workforce for health. And I think coming on to that, my second point is that I think we need more mobilization of patients, families, civil society. And I think it's very interesting that, like these development of the patient councils in places where their voice is not heard, it's got to be strengthened. And I think that, and there are examples which show us how to do this. And I think maybe the third point is around, we have to, patients, civil society, NGOs, have a strong place at the policy making tables. During COVID, they disappeared. Patient groups were sort of disbanded. They just didn't function. So building back better, surviving, sustainability, I think it's really, really important that we work out how to strengthen the voice of and include patients in policy-making circles, as well as in clinical practice, really making shared decision-making and nothing about us without us, really making that a reality. And I think that requires a lot of energy and commitment by all of us here and those online and many, many communities beyond. Thank you. And would you now kindly thank the panel for their great presentations.
Thank you very much, the panel and everybody who's joined us online. I think the call that Judy has just made is, it's almost revolutionary to say that patients take over your health system. And I hope this call is heard at the World Health Assembly when they debate this issue tomorrow morning, on Monday morning, about how we are reorienting. Now, come and have lunch with us. It's very near, it's just around the corner, in fact, straight through there. Let's network, and please do stay for the last session, which is about who pays for it all. Actual technology assessment, and that one is the one, we've got some big speakers for that. Please join us for lunch and let's talk further. Thank you.
Yeah, something like that. I think, yeah, absolutely do. I think I mean, the section Ray was talking, the sort of analysis section.
Yeah.
And if you go to
just
the BMJ website,
Yeah.
and look at advice to authors.
Yeah.
And if you go to the analysis section, you will see that there is a form for pitching ideas.
Oh, okay.
So you can pitch a proposal for an article to that team, because it isn't research, it's analysis and debate. And I think, you know, yes, I think no, but it's based on research. No, but it's research. It's not a research paper as such, but it's based on research. So basically, it's evidence-based analysis of the research.
And it's
so you could,
it's
but the point is in the analysis section, you as the experts in this economic analysis of self-care and where it's going and where it's taking us, you can write that picture. For our editorials, we would have to get somebody completely independent of you.
That's right.
To write that. You see, that's the point. Nobody is. So I think the analysis section is one pitfall. Okay. And I mean, just going to picture, they are. To be honest, they should do a lot more commissioning on the basis of good ideas, and I think it's one of their, thank you so much, one of their targets is to do more commissioning. So it's great for them to have good ideas, as this self-evidently is.
Yeah.
I mean, I will go back, and in fact, what I might say anyway is just write a note to that team and say, look, I've heard you, and I think this is great that you'll be writing.
And I might send you